For increased same-day pathways, a requirement would consequently seem to be immediate mobilization in the PSU since it's feasible and safe. Use of multimodal analgesia while minimizing the use of opioids is likely to have contributed to the immediate mobilization of our patients undergoing colorectal surgery. Strength and limitations. This was a pragmatic feasibility study in which mobilization after the surgery was stressed to its limit by initiating physical activity immediately on arrival at PSU. Careful description of the mobilization protocol and safety routines allow replications in other settings. It could be argued that the small size and the lack of background populations are limiting generalizability of the results. However, uniform results regarding of the variation in the type of surgery, the surgical approach, age, and sex suggest that the approach is adequate in the initial inclusion of more patients to the test to test impacts on the later recovery outcomes after colorectal surgery. Another limitation is the lack of patient-related outcomes. The references are given here. Thank you.
Okay.
Yeah. Can I ask you a few questions?
Yeah.
Yes, sir.
We can discuss.
Now, tell me, is it feasible from your end to replicate whatever you have just read out in this particular study? Is it feasible from your end?
Sir, it is feasible provided, sir, we have a bit of manpower because this study requires at least two attendants to be with the patient during the mobilization routine and also a skilled physiotherapist to initiate the mobilization.
Yeah, suppose you are provided with all these manpower you are talking about. What is
Yes,
the
sir.
most important thing that you should do pre-operatively to ensure that this particular protocol can be, implemented successfully?
So pre-operatively, sir, the patient's physical activity should be initiated. If the patient is not so active and already is a
No, most,
person who doesn't want to.
yeah, that's right. So what you must do is a proper counseling. That is part, yeah. Pre-operative counseling is very important. If you can explain to the patient what you are going to do if suppose you admit a patient without proper counseling and tell him to get up 30 minutes after surgery, so it becomes very difficult for him to do.
Yes,
But
yes.
if you counsel the patient properly, pre-operative, that this is what we are going to do, and it will not be difficult for you to follow our instructions. Many of the patients will be able to do it, but counseling is very important, isn't it?
Yes, sir. Yes.
And can you just summarize what are the what do you mean by ERAS, and what are the components of the ERAS?
So ERAS protocol is a standardized protocol which is being followed in most of the hospitals. It is the pre-operative, the operative, and the post-operative management which is given in the ERAS protocol is there for the quick recovery of the patient post-surgery and we try to discharge the patient as soon as possible in their home setting because the recovery is faster, sir. But if the patient has no comorbidities and uh, any
Yeah,
such
yeah,
complications, so
understood.
yes.
Understood. So, what are the pre-operative, things that you should follow? What are the intraoperative and what are the post-operative? Uh,
So pre-operatively, sir, we
types?
first want the patient to be physically fit, nutritionally fit, healthy, so that he can take the operation well. Then, sir, if they are consuming alcohol, tobacco, so we want them to stop. And we also counsel the patients about the surgery, the length of the stay that it could take, the kind of
That
risks
is
that
that is the counseling, pre-admission counseling.
pre-MCD counseling, yes, sir.
Yeah. Then
During the pre also, sir, pre-operatively, sir, we give them analgesia paracetamol, so that during the operation and also while
Preoperative, see, which was the type, I mean, when was it first implemented? Which type of surgery had first this ERAS protocol implemented? It was on colorectal surgeries. It was first tried. Okay. So, and it was successfully tried. So what are the components of this ERAS protocol? That's what I wanted. Like preoperatively, you must do a counseling, as we said. Then,
yes, sir.
then
Then sir,
there is a
pre-operate.
there is you know, scope of carbohydrate loading preoperatively.
Yes, sir.
Avoid prolonged fasting. Don't go for, you know, bowel preparation. Okay, or selectively you do it. Like don't go for mechanical bowel preparation. Okay. Then what else?
So antibiotic prophylaxis,
Very good. Antibiotic prophylaxis.
thrombin
Thromboprophylaxis.
thromboprophylaxis.
Yes. Then these are
Then
the
sir,
preoperative measures that you can implement so that the protocol is carried out successfully. What are the intraoperative?
so intraoperative use of analgesia, uh,
Yeah.
multimodal analgesia, anesthesia inductions, and anesthesia
What type of
maintenance.
what type of anesthesia is advisable for proper implementation? Yeah.
So COX inhibitors are used, and
Anesthesia.
anesthesia, sir. Oh, sorry, sir. Anesthesia, sir. Uh, for sir induction, sir, fentanyl is used, and
Very short
fentanyl
acting and short acting
acting
anesthesia.
anesthesia, yes, sir.
Yes, and then
And so for maintenance, sevoflurane is used.
is it general anesthesia that is recommended, or it is epidural anesthesia
The
along with?
epidural anesthesia is recommended, sir. General anesthesia.
So you give short acting anesthetic agents and then continue with epidural anesthesia.
Yes.
What other intraoperative measures that are advised?
So intraoperatively, sir, so we want the surgery to go with minimum blood loss, and it's as quick as it can, because already, sir, the OT is it's
All
kind
right.
of
Yeah. Avoid excessive fluid and electrolyte overload. Okay, and maintain normothermia. That is important. Do not let the patient be hypothermic. And intraoperatively also another important thing is that do not put brain antenna unless it is absolutely required. Isn't it?
yes, sir.
All right.
Yes, sir.
And for the post-operative measure?
So post-operatively, control of nausea and vomiting and pain is the most important aspect, and early mobilization is also one of the important aspects of ERAS protocol. And we want the patient to mobilize as soon as it can, start taking enteral fluid as soon as they can.
How do you
And
take care of the post-operative pain?
so post-operative pains, paracetamol is the most common drug which is given.
And you have got a catheter, epidural anesthesia. The catheter is introduced there, no? So you can use that catheter for maintaining post-operative analgesia as well, isn't it?
Yes, sir.
Avoid putting, just like you avoid putting drains improperly, try to avoid putting rice tube post-operatively. Use measures to avoid post-operative nausea and vomiting. Then if the patient is having a catheter in place, you have to remove it as soon as possible. And then most importantly, allow the patient to start taking orally as soon as possible. And avoid opioids. That is very important. And as you said, early mobilization. And so these are the things that should be followed for proper implementation of ERAS.
Yes, sir.
Yeah, actually, this is extension of ERAS protocol, and most of us are not using ERAS protocol in our practice. So we are not discharging patient in 38 hours, and most of our patients are such that we are not going to the exact ERAS protocol. And you see, the lab versus open is lab is preferable for such type of ERAS regime. So most important is one has to decide about the ERAS protocol and then start mobilizing in the pre-anesthetic, post-anesthetic care unit. So all points has been discussed. So unless you have this protocol in place, it is very difficult. You see, our manpower even in PACU is limited. So one patient needs to be supported. He needs motivation, good pain relief. So if these are not possible in a PACU, then it is difficult to mobilize and achieve such uh, result within half an hour of receiving at PACU. Okay, but this is a good study. Actually, the point of early mobilization was reducing the chest complications. You give thromboprophylaxis. Once a patient is mobilized, this thromboprophylaxis may be curtailed. In that case, this just mechanical things will keep on working. If patient can keep on working, the dose of LMW can be reduced. The duration of therapy may be reduced.
Yes. Yes.
Okay. I think Dr. Bachu, you can pass on to the next topic.
Yeah. Sure.
So the next topic will be presented by Dr. Diptaman Nandi, who is a senior first year resident at MR Bangalore Hospital. So Diptaman, you can share your screen and present.
Yes, sir. Good morning, my respected teachers. I am audible, sir.
Yes.
Yes, sir. This is a journal presentation. My topic is, next slide, please. This is the my topic is comparison of infected malignant tumors of the right and left-sided colon. Is there any difference? This is journal of from the Indian Journal of Surgery, October 22 edition. And this is the study was originally done by this Adrian Lazio and others. Next slide, please. In the introduction part, colorectal cancer is the third most common cancer worldwide. In Hungary, CRC is the second most common cause of cancer-related death in both men and women. Colon cancers can be divided into two groups based on the localization of the primary tumor. Right-sided colon and left-sided colon cancer have different embryological, physiological, genetic, and clinical characteristics, which led to differences in prognosis and in the outcome of disease. Anatomically, the proximal colon arises from the midgut, as it is major blood supply to superior mesenteric artery. The distal colon arises from hindgut, it is supplied by inferior mesenteric artery. Clinically, patients with RCC are older and more likely to be women and are seen at first with more advanced and poorly differentiated tumor stages. For these above-mentioned reasons, numerous studies have reported that oncological outcomes of colon cancer are different according to the location of the tumor. In the literature, there are some controversial results regarding patients with non-metastatic colon cancer. Some studies have suggested no difference or better survival for right-sided tumors, but two meta-analyses showed that survival is worse for the patients with right-sided colon cancer. The effect of sidedness on determining the CRC prognosis still remains controversial. Authors aim to analyze the clinico-pathological and oncological differences among patients who had been operated for colon cancer. Patients and methods study design. Study was done in Department of Surgery in Hungary, who underwent colon resection for malignancy between 1st of January 2021 and 31st December of 2018. Authors analyzes the data of patients. Inclusion exclusion criteria. The inclusion criteria were as follows: patients older than 18 years, patients had pathologically confirmed colon cancer, and the radical surgical resection was performed. Exclusion criteria include patients who had unresectable tumor, patients who had rectal cancer whose primary tumor was about anal to 15 centimeters of anal bulge, patients who had undergone preoperative chemotherapy before surgery, patients who had R1 and R2 infections, and patients who lost to follow-up. Patients record assessment and follow-up. Authors analyze CA levels from the preoperative routine blood test based on the international reference values. The resected colon tumors were histologically pathologically classified according to CNM classification. Besides the tumor markers and histological research, authors also investigated the types of surgery, laparoscopy, or open postoperative complications and oncological therapies. They attempted to identify unique clinicopathological characteristics of RCC and compared with those with LCC. In the patient study, rectosigmoid, descending colon, and static texture tumors were considered LCC. Transverse colon, hepatic texture, ascending colon, and fecal tumors were considered RCC. All evidence of recurrence was obtained from the patient medical record. Patients were followed up every 6 months. A total of 267 patients were enrolled in the study. 49.8% patients had RCC, 50.2% patients had LCC. Authors examined overall 149 men and 118 women with a median age of 67.93 years. The median follow-up period was 29.13 months, ranges 0 to 49. During the follow-up period, 35 patients died. Laparoscopic surgery was carried out in 48 patients and open procedure was performed in 219 cases. In 56.18% of the patients, there were no lymph node metastases. No significant difference was determined in sex, age, clinical mode of presentation, and tumor size comparing the two sides. Patients with RCC were significantly more likely to have mucinous adenocarcinoma histology. The value was 0.037. With Kaplan-Meier log-rank test, no significant differences were revealed in overall survival between RCC and LCC patients. The value was equal to 0.381. There was also no significant differences in overall survival between two sites in terms of age, sex, tumor size, end stage, CEA level, type of adenocarcinoma, number of reoperations, and post-operative complications. Statistical analysis. Authors use Stata software to perform all statistical analysis. Categorical variables were presented as a frequency or rate. Continuous variables were presented as the median with quartile range or the mean. For categorical data analysis, authors used Pearson's Cycloid test to determine the statistically significant difference between the expected frequencies and observed frequencies in more categories of a contingency table. The Kaplan-Meier estimate method with a log-rank test was used to accomplish univariate analysis. This is a diagram, confirmed diagram. All patients who had histopathologically confirmed CRC in the study period. The total number of cases were 452, and including the excluded criteria. Study population was done among the 267 patients. Right-sided colon cancer patients were 133, and left-sided colon cancer patients were 134. Regarding the discussion in this cohort study, controversially to an article published in 2008, there were no significant differences in age, sex, age, and tumor size comparing the two sides. However, similar to the result of a systemic review, we found significantly more mucinous adenocarcinomas in RCC. Reviews and multiple studies have reported clinicopathological or genetic differences between RCC and LCC. With regard to overall survival in the study, stratified analysis demonstrated that there was no significant differences between RCC versus LCC patients. Examining the entire cohort, regardless of naturality, authors proved that preoperatively elevated CE levels significantly reduced survival in patients with colon cancer. Adjuvant oncological treatment did not significantly affect survival. Significant difference was revealed in survival in terms of pathological, stage, grade, and perineum and vascular invasion. In case of lymph node positivity and distant metastasis, survival was significantly worse, and reoperation or post-operative complications also reduced survival. One previously published article also emphasized the importance of lymph node positivity for cancer-specific mortality, regardless of tumor sidedness. This is a table showing univariate and multivariate Cox regression analysis of survival. Univariate analysis shows that histological mucinous and non-mucinous types, a p-value was 0.526, and in tumor size less than equal to 5 or greater than 5 centimeter, p-value was 0.94. In end stage, it was 0.004, and in multivariate analysis, it was 0.464. In CLS, next in the conclusion part, comparing right-sided colon cancer and left-sided colon cancer, authors found significantly more mucinous adenocarcinoma histology type in right-sided colon cancer, but there was no significant difference in overall survival. Based on the conflicting previous study results, present findings repeatedly highlight that the relationship between tumor location in the colon and overall survival is not straightforward. It is important to plan further clinical trials to clarify the existence of the difference between the two sides of the colon for the purpose of individual patient management. Thank you, sir.
Ditaman, I cannot follow the result of this study. Out of these patients, what is the they have about 29 months of follow-up. So
Yes,
what
sir.
is the result in the patient with right colonic cancer, the relapse, the 29 months review at the end? I cannot follow the result in the particular study. I understand at the end they are saying this is comparable.
Yes, sir, but they are mainly saying that to some percentage, right side is mucinous adenocarcinoma is
That is shown.
uh,
But what I'm saying is, what are the other parameters? Because we know that right-sided colon cancer is more common in females. What is the in the present study? Is it not statistically significant that it is more common in females or is equal? I want to understand the result of study in this particular study.
No, I think they have mentioned that there is no significant difference in this particular study. They
That's
said
what I'm
that
saying.
there
I
is
was
no
just wondering that because
Ah,
previous
ah.
studies has some
Yeah, yeah,
confusion
exactly.
in regard to right-sided is worse than the left side.
Yeah, exactly.
Okay.
They found no difference in the sex, age,
Yes,
clinical
yes. At
presentation.
only mucinous is more on the right side. But
That is
again,
the only
mucinous is one of
confusion.
the poor prognostic marker.
Exactly.
Mucinous adenocarcinoma has poorer outcome than other varieties of colon cancer. But have you find any other study? Have you gone through any other study where right side was compared that right side is worse than then? What was their study endpoint?
sir, I
You should
didn't
read
look
some.
into details in the other study, but I will
No, you should. You may
surely.
quote. You see, in the same journal club, you can quote few other studies. That in this study,
Okay.
right side was this, left side was this, but this study is showing a different view. Have you gone through any other study where the right side was discussed as worse than the left side?
No, sir, I didn't go
That you
to
have to
the
read.
other study.
There you have to read.
Yes, sir.
That is the importance of the journal club because you have to read few more journals to have a discussion on this particular study.
I think the author has somewhere mentioned that their study is contradicting whatever most of the studies that
Yes.
were the
Yes,
results
they
of most of the
mentioned.
studies done previously.
Yeah.
I
Yes.
mean, he is accepting, the author is accepting that his study is not in tune with the results of other studies.
Yeah.
Yeah. One, I think somewhere he has mentioned it here.
Yes, author have mentioned in a slide.
Yes. Because it is established. So the most of the studies published till date has revealed that right-sided cancer is more common in females. Right-sided cancer is more common in little earlier age group. Right-sided cancers are more aggressive, and right-sided cancer has a poor survival. Most of the studies has revealed that earlier. Now they are saying this study is trying to emphasize that there is no significant difference in these sites.
That is his basic conclusion.
Yeah.
And one more thing he said is that if you find that the CA level is significantly, I think that is also acceptable. I mean, accepted fact that the CA level is significantly raised, then the prognosis is adversely, directly proportional. The prognosis is directly proportional to the level of the preoperative CA level.
Yeah, you see, baseline high CA level indicates advanced disease.
Yes. So that is also nothing new. New information.
Yes. I think we can have a study on our own to assess the outcome in this right? Because we have a lot of patients we have a mixed population of patients, and we have good number of patients with colon cancer.
One thing that is not explainable is that though he's saying that, as we all know, that mucinous adenocarcinoma has got a poorer prognosis, and they are finding that on the right side, mucinous adenocarcinoma is more common, but still,
Yeah.
overall prognosis is in their study is same. The survival and other things, recurrence.
And you see, 29 months is also not a
But a
adequate
short,
period
yes, short follow-up.
to say that overall survival.
And sample size also, I don't think is just about 133.
Yeah.
33,
On
34.
on either arm, yes.
Either arms, yeah.
Okay.
Okay.
Mhm. Okay. Thank
Thank
you,
you.
Ditaman. Ditaman, you must read
Fine.
some related journals, because it's a contradictory point being coming up. So you should present other studies. What was the study in this similar line, and what they found, and what is the difference in this study? These are all important.
Because
Yes,
you are, after all, and still a trainee, and if you say that there is no difference between right-sided colonic cancer and left-sided
No,
colonic
still,
cancer in examination, you
it's
will
not
be in a
established fact.
problem. Yeah, yeah.
Established fact still today is right-sided colon cancer and more aggressive, worse outcome.
Yes.
Okay, sir.
Okay.
Thank
Okay,
you,
Dr.
sir. Thank you,
Bhattacharya.
sir.
Thank you.
Thank you. Thank you. Thank you.
Thank you.
Thank you.